ora.
Thanks for joining us today. We're just waiting for a few more people to hopefully put their cameras on so we know they're here.
Kia ora, Jess.
Kia ora. Everyone had a good morning?
I flew back from Christchurch today into Wellington.
Ooh, was it bumpy?
Yes. Yeah, I was supposed to come back on Sunday, but it got cancelled because of the weather. And then I was like, oh no, the weather looks heaps better. And then, as I got onto the water, I was like, oh yeah, no, it's still windy up here. And I saw some flights to Auckland from Christchurch was still being cancelled. And I was just like, oh no, I think I live here now. I don't know if I'm ever getting home.
You're stuck.
Yeah. I do, if it turns out, I do know a few people down there, so that was quite good. But yes, no, I've come up here and I'm like, yeah, no, Wellington is living up to its name.
It's not a skirt wearing day.
No, and I had thought that because I did a wee spot shopping when I was in Christchurch for the conference, and I got this nice skirt, and then I kind of looked at the weather. I was like, I won't be wearing that.
No.
Excellent. Well, we've just passed 1:15, so we may as well jump in. So I just want to say thank you to Jess from Practice Plus for joining us today. Unenrolled population and closed books and everything is sort of quite a big conversation across the country, and it's been brought up to me a couple of times. So I've been trying to sort of brainstorm ways of, like information we can help, distribute and collate to try and focus on an unenrolled population, because it is quite a hard one. But I think, Jess is going to talk to us about how Practice Plus can help with that in some ways, which is great. So Jess, I will pass over to you.
Great, thanks Petra. So I'll just, I do have a bit of a presentation, so I'll talk through that today, but I'm happy if you have any questions or want to stop me, just feel free to Petra can maybe keep an eye on hands or something and give me a prod if you want me to stop. So, all right, can you see that? Cool. Okay, so I thought I'd give a little bit of context about Practice Plus first and then kind of delve into the unenrolled space. Apologies to the likes of Amelia, who have probably know the inside and out of Practice Plus. So yeah, so I probably should introduce myself. I feel like I'm part of the whānau, but for those that are new, kia ora, Jess White, and I'm the General Manager of Practice Plus. And wear lots of different hats as well. Dr. Emma Calvert is our clinical director, and she usually kind of co-presents with me, but she's, where is she today? She told me she was in Venice or somewhere like that. So at the opera. So yeah, but will now be asleep. So yeah. So yeah, just briefly in terms of Practice Plus in the background, we've been established for now close to 2 years, coming up 2 years in January. We're a virtual telehealth service established by Torda Compass and Pinnacle Health, as well as a whole number of PHOs across both the North Island and the South Island now. So we were built alongside our general practice network, so we co-designed the whole of Practice Plus alongside them. So we have some really key service design principles. So we're seen as an extension of general practice capability and capacity. So we're there to complement, not compete with our general practice partners. And we want to complement their virtual care that they're already doing. So likes of the healthcare home model, really trying to encourage them to keep going with their GP triage and their video consults and things like that. Practice Plus isn't going to replace that part of the model of care. We're complementing that, and particularly in the after hours space. So when we always say, when general practices are lacking capacity or their same day acute appointments are taken up for the day, they have a trusted virtual health provider in Practice Plus to refer their patients through to. So very much, again, like the healthcare home model, it's about change management, making sure the whole team is involved, understands the service, and that's a really key or critical success factor in Practice Plus. So as I mentioned, we're pretty much GP overflow, and I'll talk a little bit about what we see based on that, and also after hours as well, supporting in that space. So we go up to 10 p.m. In the weekdays, and we're 8 a.m. to 8 p.m. in the weekends and public holidays. So very much our model is delivered when general practice is closed or doesn't have capacity. It's a little bit like your hairdressers now, or your bank. You go online, you can book yourself, and we do have a kind of an assist model as well that I'll dip into. But it's very much a kind of a self-management service. Go on, book yourself, pay online, and pick an appointment at a time that suits you at your convenience. All right, I've talked a little bit about complementing, and the other two key points here is that we don't claw back from any practices if we see their patients, and we're definitely not an enrolling service. So here's some of our key values. I won't go into a lot of depth about this, but as I mentioned, we're very much a partnership model. So we partner up. We're a marriage made in heaven with our general practices. We've definitely baked in a lot of equity in our design and also in implementation. So one key part is that we honour the community services card rate of $19.50. So that's one key equity part, along with a whole equity strategy that we've built into the service. We're very much about continuity. So continuity sits with the enrolled GP. Again, we're not in the place of replacing that. It sits with the GP, the patient, so we don't have a problem linking patients back into the enrolled GP if they have one. We've got strong clinical governance and audit oversight in our service, and we're very much innovation. So we've got a roadmap that for the next 3 years of where we want to head, and it's very much in that innovation space. So this is around the same day demand. So again, very much complements kind of general healthcare home model of care. So between 8 and kind of 5, if they're doing extended hours as part of their healthcare home, then that would reach out to kind of 6 or 7 o'clock at night. So patients are linked into their enrolled general practice. So that's their first point of call of any time during the day. But where we see Practice Plus fitting is right in the middle between general practice and after hours and ED. So trying to preserve having to send patients off to a long waiting list or a waiting room where they have to sit around for 2 or 3 hours. If we can deal with it virtually via Practice Plus, then we're hoping to kind of circumvent some of those patients having to go to those after hours or ED facilities. So what do we see? So here's our ethnicity and demographic breakdown. So very much kind of bunking that perception that virtual care is very much for our kind of younger cohort or our New Zealand European, that, you know, it's difficult for some parts of our population to access virtual care. So, you know, we've got over a 20% rate for Māori accessing Practice Plus, but more interestingly, you know, it's our quintile. So here you'll see our two biggest cohorts of patients is in quintile 4 and 5. So that's really encouraging that we do have priority populations accessing virtual care. We're happy to share any of this. I'm just thinking on the side and talking out loud. If this helps with some of your change management discussions with practices about who's accessing virtual care, then we're happy to share any of this data to help kind of offset some of those change management discussions, because it very much kind of bunks the trend of, you know, we've seen over 12 people in the 90 plus age group, but also down in that kind of 0 to 9 or 10 to 19 age group. We still see a lot in that cohort. So it is across the age spectrum and also across the quintile and ethnicity spectrum. For CSC, we see 24%. So that's most likely due to our $19.50 fee, and then rural is sitting at around 19%. Across New Zealand, this is all our little red dots are people we've seen. So as I talked about, we cover around 10 PHOs. So that will kind of predominantly showcase where patients are being seen from. But we do cover the whole of New Zealand. All right, let's dig into the unenrolled. So we did do a bit of an analysis to see at the 18-month point what we're seeing in Practice Plus. So we've seen over 1,000 or 1,300 appointments have taken place for unenrolled. We did have to unpick that because we do see quite a few international patients. So the kind of proviso with that is if they don't have an NHI, that usually means probably they're a visitor to the country. So that's kind of how we've split it. So around 867 appointments for patients with an NHI that don't have an enrolled practice. So we sync all our patients to the National Enrolment Service, so that allows us to identify if they are enrolled with a practice or they haven't got a practice allocated to them. So we did a little bit of matching between our unenrolled population we see and our enrolled. So our resolution rate, so this is what our clinicians resolve, is sitting between the two cohorts, enrolled and unenrolled. We're still resolving about 90% of what we see. In terms of our failed encounter rates or DNAs, so again, it's pretty similar. Enrolled, we see a DNA rate of about 1.6 and unenrolled patients around 2%. So pretty small in the grand scheme of things. There in the bottom right-hand corner is patients with repeat presentations. So 632 of those patients out of the 867 have just come the once, and then now we're starting to see some of those unenrolled patients coming back to see us 2 or 3 times. In terms of demographics, so you see we've done analysis against unenrolled and enrolled by ethnicity and also by quintile. So 58% of our patients in the unenrolled service or unenrolled cohort are European, 15% Māori compared with the 21 or close to 22% across the board in our service, and matching or alignment is 4% with Pacific. There you'll see the distribution again against the population and what we call kind of the hotspots for our unenrolled pop by region. So that might be interesting for some of you, depending on where you're based. And, you know, where do the unenrolled patients come from? We're finding that they either come through pharmacy, so they've presented to the pharmacy to get some medical help, but it's slightly out of the pharmacy scope. So we've got a lot of pharmacies on board now who are using Practice Plus. Obviously, EDs and hospitals see a lot of unenrolled pop coming through, so they can promote Practice Plus. And then obviously people ringing up their local general practice and not being able to get in due to closed books. So it's a good tool for practices to have on hand to be able to then promote or divert patients into Practice Plus. Jess, I saw that you had your hand up.
Yeah, I just wanted to clarify, Jessie, I might have missed it. The data that you just presented on the slides before with the ethnicity breakdown, is that for the I think it's 1,133 in the 18 months, or is this the 867 or so that had NHIs?
I think it's this is the whole, the total, the 1,000, yeah, 325. But of course, you know, if you're looking at kind of international population, you won't get Māori and Pacific a lot through that. So
yeah, but if you took them out, then the Māori rate would be higher, is what I'm trying to say.
Yeah.
Yeah, cool. Thank you.
Right. Okay. And then a bit of a case study. Oh gosh, got a typo there. So I wanted to use the Wairarapa region just as a bit of a proviso. They were the first region that proactively reached out to us in terms of their unenrolled pop. So they identified they have around 2,500 to 3,000 of their community unenrolled. So they've got significant GP workforce shortages. They've identified around a 6 FTE gap in workforce and FTE for that community. So as you can imagine, most of the practices at that point in time had closed books. A couple have just started to open up, which is great. I think Greytown Medical has introduced a paramedic and has been able to then lift that closed lid off their service. But this was a really good opportunity to provide some of that kind of first point of care. So Te Whatu Ora Wairarapa, the PHO, Te Ora Compass and Marsden Medical and ourselves came together and we, had a couple of workshops to work out what was the need and what kind of model would best fit this population. So obviously virtual, we're one piece of the jigsaw. We're not the whole solution, but we wanted to work together to be able to provide a service for this unenrolled population. So what we came up with is a kind of a hybrid model. So either, as I said, those kind of points of contact with pharmacy, ED and general practice where unenrolled are turning up and seeking care, that they were given an option to be able to promote Practice Plus. So people could go home, book themselves and book an appointment. And those were kind of, that's the ones that don't need support, are quite happy to go and do that themselves. Then we identified a cohort of population that would find that really difficult, either due to, not having devices, not having data, and just finding it in general hard to connect virtually. So we wanted to provide them an in-person or a face-to-face option. Marsden Medical, while they had closed books, did say, look, we've got space in our facility. We've also got kaifina or health coaches or HIPs that can support in this space. So they were quite happy for patients, unenrolled patients, to come to Marsden Medical and use one of their rooms with one of that workforce. So when at the time of booking, they would just identify that they needed help and that they could go into Marsden Medical. So it would take, they wouldn't be able to book on the day. We needed a little bit of time to be able to arrange that. And then the person would be told what time to turn up at Marsden Medical, and that workforce would be there to present them and help them. So for example, they would be able to do basic obs, so get a blood pressure, get weight, get height, and then they would work out whether they needed to sit in the room with the person or whether they could leave the person to the appointment. So based on what was needed in that consult, for example, in that space, we did an ECG for a patient, we did many blood pressures, but also there was an opportunity to provide flu and COVID vaccinations as well, because many of these unenrolled population have lots of delayed care that we wanted to catch up. And that meant that when practices did open their books, these patients were then more up to date with their care. They got put into the referral system into secondary care. So lots of these were behind in some of their screenings, but also, needed to access specialist care. And with that being delayed, at least Practice Plus could get them into the system and get going with some of their care needs. So it was a really good kind of partnership model. We're carrying on with that. So we did a little bit of a kind of pilot or prototype, and now we're going to roll that out to at least kind of early 2024 and then reassess. The next phase in this kind of what we've identified as we've gone along, and we've had other discussions with this in different regions, is that how do we wrap more PHO services around this population as well? So some of the regions have things like PHO diabetes nurses, navigators, lots of different mental health services that we could actually comprehensively wrap around this patient as well while they're in our care. So happy to have those kind of regional discussions, what's available. And then what else we've been doing in the space is kind of the third tier is then helping to facilitate enrolment when practices open their books. So, for example, when Greytown said, yes, we're actually able to take patients, we were able to connect with those patients who we'd seen and say, look, actually, there's space now available in this practice. You connect, here's the process on where to go to enrol. So it helped, one, the practice kind of facilitate that and manage it in a phased approach, but they also knew that their care had been started and it wasn't going to be a big surge in demand for them taking on this cohort. I'll just pause there for any questions, and then I'm happy to take you through kind of what Practice Plus looks like, but realise I've just talked a lot and there's probably a lot of information in there.
I just had a quick question. Do you know what type of staff they were using at Masterton to sit with the patient? Like, was it more often, maybe like an HCA or like a registered nurse?
Yeah, so we identified a Kaiwhina to start with, and we thought that would kind of help with the social determinants and the social needs for that patient. In terms of, obviously, they have a certain scope. What we did need is also a clinical scope involvement as well. So whether it be HCA, depending on what their scope is, or a registered nurse, just because we did need things like dip tests, pregnancy tests, blood pressures. Obviously we needed an ECG. So depending what scope the HCA has, that might sit right inside what they're capable of doing. So there's a kind of a balance of lots of social need and a lot of and some clinical observations to help increase the scope of the virtual doctor.
So would you get a bit of an idea of what they were coming in for when they book, or is it just book and then you kind of it's a bit of surprise what they're coming in for?
So when you book, and I can show you this one, how you book appointment, is you've got an option to add a appointment, like a note. And most of the time the patient, or if someone is assisting them to book, they would write, what it's there for. And if they've already had ops done, they can pop that into the notes. And the doctor sees that when they, prior to the consult, so they get a good idea on what they're coming in for.
Yeah, so then Masterton could kind of plan who they think may be needed for that appointment. Oh yeah, perfect. That sounds good. Yeah.
Yeah, so for the
Thank you.
telehealth assist model, it needs to be kind of 24 hours in advance to line up everything that you need. So it's not a case of booking and then ta-da, turn up and everyone's there waiting for you. So we do need a little bit of lead-in time for both services to work out what's appropriate. So
excellent. Thank you.
Is there any other questions? And then Jess.
I just have a quick question, and just in terms of kind of patients that might have long-term conditions, and where you've said, you'd connect people with the services that are available within the PHO. Are you finding that more and more, because 2,500 to 3,000 patients for Wairarapa, for example, that's almost a new general practice. So you're kind of creating a new kind of cohort of patients who are now being enrolled by the PHO, managed by the PHO, if you know what I mean. So yeah, what are your kind of plans with that? I mean, you have indicated that as soon as a practice opens its book, you try and make the connection or introduce that patient. And I guess would you prioritize, so those ones, say, with a long-term complex kind of conditions, they'd be first off the list to get into a practice?
Yeah, so I've got a few thoughts in that space. One is we're really clear that we're not an enrolling service. So while you say the PHO's enrolling, they're absolutely not. This is just a kind of an interim measure, and wrapping as much kind of care around the patient as we can in that kind of point in time. So we have to be really careful in that space, what we're providing and what we're not providing. So in terms of priority to go into that, when it's open books, we didn't prioritise. It might be something that we look at depending on that. we were probably lucky with the intakes is that first kind of open book is they could take all the patients that we'd seen. So we didn't have to kind of prioritise. We were able to offer enrolment to all of them, and then it was up to them to take it. But if we get that, we would have to probably manage that quite carefully, and it might be children. There's obviously all ethnicity. There's a lot of ways you can cut it, but we'd have to be quite careful how we do that. So and then going back to the PHO services, that's something we've identified to add in kind of as we grow. So we probably haven't done that enough, and what we would like to do is kind of mature into that space much more, because some of the PHOs have excellent services, so it's how we kind of wrap that in.
Yeah, and I guess it's just making sure that people don't use this as their kind of way of receiving healthcare. Like you'd said from the beginning, this is about complementing and supporting general practice. So ultimately, we want every patient enrolled, but there is a group of patients who just are in that gap, aren't they? So yeah, awesome. That's great.
And one of the things that we were really set on is providing this cohort or this whānau 30 minutes. So we didn't want it kind of the 15 minutes and now kind of put a plaster on and move on. So we were really set on providing at least 30 minutes for these appointments to give our clinicians and give that whānau really good comprehensive time with a clinician that they've been missing out on. So that's one thing that we've been able to add into the model.
Yeah. And, thinking about, patients who, or whānau who, don't have access to transport, for example, they're just great opportunities for people to access and access help and services to meet their needs. So, yeah. Cool. Thank you.
All right. Petra, I've got a few more slides, but what's my time? Have I got enough time?
No, you're still good. We've got about 20 minutes to the end of the session. So just sort of see how we go, have a few questions, and off we have a lovely day.
Okay, all right. I'll carry on and then you can tell me when to stop. So I just thought just to, again, giving some more context, like the broader context about Practice Plus. So I've talked about kind of syncing with NES, it's a National Enrolment Service, so and NHI, so we can identify the patient and where they're based. We have access to the shared care record of most parts of New Zealand, so things like Health One down south, which is great because it covers the whole South Island, Your Health Summary up north, and the shared care record in the mid-central area. So we've got access, that's all integrated into our system, so as well as Comporto, Test Safe. So we've got a pretty good high-level clinical summary of a patient. Obviously, we don't have the GP notes, but with that data, we're able to be able to see a lot more and gives our clinicians a lot more safety in that space due to the clinical information they have at their hands. We do electronic referrals and labs, so we can do a lot of investigations and request labs. We try and find that balance of doing some care in this space and then linking patients back into their enrolled provider. We link to NZEPS, so all scripts go off securely to the patient's choice in pharmacy. And then once the care is provided, we send a note back to the enrolled GP. So the GP can see everything that we've done with the patient in Practice Plus. If we do any requests or investigations, we always CC again the enrolled GP so they can see what tests have been done for a patient and they'll get the results as well as us. So this is our website. What we do when a practice onboards is we pop the Practice Plus logo or booking appointment button onto their website. So for patients, it looks like a seamless service from their general practice into Practice Plus. Obviously, some practices don't have websites, so again, they can go directly to our website. Once they press the booking appointment button, you have to register, and we try and encourage people, a bit like the portal, to register in advance because no one wants to be registering while they're feeling sick and a bit probably grumpy, so they don't want to be kind of having to fill in this part when they want to just book an appointment. So it is the basic demographic details that we capture. We do, when you go to book an appointment, we screen out because we don't want people with crushing chest pain trying to book in a virtual appointment. And then they get this screen here. It says, have you had a virtual consult before? If they press no, excuse me, they get another kind of 5 screens, which really holds their hand on what to do next when booking. And if you've had an appointment, you don't want to read that guff again. So you press yes, and it will be straight into booking. So you want to see book for later. You can add a child. You can choose if you want video or phone. So if people don't have a smartphone or don't have an iPad, they can request a phone call, and even their home landline, we're happy to ring. That's where the appointment notes. So if they've had OBS done, say in a UCC, and they get diverted to Practice Plus, or they want to tell us what the appointment is about, then that appointment notes screen gets populated into the GP's appointment book, so they get to see prior what the patient's coming for. Here you pop in your CSC details, and that will bring the consult down to $19.50. We've got a coupon scheme, so a number of, alongside the unenrolled clinic in Wairarapa, they also get a funded coupon, which brings the consult down to the level of most general, kind of average general practice fees in the Wairarapa. So I think they pay around $45 rather than that, or it's actually $68 now. But yeah, it means that the unenrolled aren't being disadvantaged. They're getting a kind of a same level co-payment fee. So say they book for 8 o'clock, at 7:45, they'll get this this link emailed to them and text to them. They click the link and they'll sit in the virtual waiting room. They can do a pre-test call to check their sound and videos working. And then when the doctor's ready, they'll pop on the screen. So this is what you see, the top screen. So it's me and my daughter having a consult with the doctor, and the bottom screen is what the doctor sees. So they write an indice as per normal, do their work, but they get to have a really clear picture of the patient. Once it's finished, a receipt's emailed to them, and the script goes direct to the pharmacy. And we've got a bit of an Uber star rating, so you can mark us out of 5, and also patients can leave us real-time feedback. So we get lots of good feedback, and when I say good feedback, there's quality improvement there. We pop all this feedback back into our quality improvement cycles, and we've made some really good changes to our service based on that feedback. So we're regularly looking at that. We also get lots of comments from our clinicians who've said, I've never had so much feedback in general about my consultations. What we do is we kind of send to them probably every fortnight, the clinicians, kind of a bit like you kind of PHO bulletins. We send them some comms on general service stuff, but then we also add in all this feedback, so they get it regularly sent to them. I just wanted to show you our kiosk. So we've got actually quite a bit of interest in this. So both we've got many regions, UCCs under a lot of pressure at the moment. So they're quite interested in these. They're just a booking kiosk. So what the biggest fear in that we've been told is patients who are diverted away from urgent care clinics, that they're worried then they won't be able to get an appointment at Practice Plus once they get home. So at least there with the booking kiosk, before they leave either ED or the urgent care clinic, they can go on, book an appointment with Practice Plus and go home knowing that they're going to be seen at, say, 8 o'clock tonight or 6 o'clock tonight, and they're not having to navigate the system to try and find somewhere to be seen that day when they're really sick. So that's something that we will be introducing in many areas. Oh, this is a patient feedback. So we sit at around 4.7 stars out of 5. And I've talked a bit about that. This is the kind of patient feedback we get on a daily basis. I think 1 in every 5, it might be 2 in every 5 consults we get feedback written. Okay. What do we see? That's another question we get lots of. Very similar presentations to general practice, because we're an overflow service. What general practice see is what we see as well. I've talked about lab investigations. We do ACC 45s, ACCs 18, depending what they are. And also wins, again, depending how much information the clinician's got at hand and how comfortable they feel to do those wins. But you'll see the range of clinical presentations, so respiratory, ENT, gynae, gastro, mental health. So we see a pretty wide range, and then exacerbation of long-term conditions. So we're not providing long-term condition management, but say, for example, if your asthma flares up, then we can do that kind of episodic care. I'm going to go into this. Resolution rate. So we are managing around 90% of what we see, which is a pretty high resolution rate. I think because we were trying to unpick this the other day, because it is quite high, is that I think because a lot of triage is done in the general practice and then patients are diverted into Practice Plus, the practice is probably doing a lot of that kind of screening out for what's not appropriate for telehealth. So you'll see there that we send a small cohort, 3% off to ED, but what we do, and we don't have a problem with, is sending back into a GP review. So we might start some of the care, but for example, say to the patient, I do think you need to be seen by your GP in kind of a week's time. That's it. Thoughts?
Excellent.
Questions?
I thought that was really interesting, because I obviously do know quite a bit about sort of Practice Plus and the virtual, GPs, but it's always good just to hear kind of that extra information on it, and seeing some of the stats is quite interesting. Did anybody have any questions on that? Potentially, how to get, because you can do, oh no, I forgot where I was going with that. Ignore me. Oh, actually, no, it was. So anybody can access you. It doesn't have to be through a practice or a PHO. It's just like, because you get obviously a lot of travellers. So do people just Google, you find, if they're not really?
Yeah. So what we've added to on that closing off of the consult, along with that feedback, we asked where patients were referred from. So I think on average 60% get referred from their general practice, and that's what we're wanting. It's that general practice model. Around kind of 11% is via internet search. So someone Googles it. I think a little bit of that is people who go on HealthPoint as well. So and then I think it's about 7% from pharmacy, 3% from the urgent care or accident and medical centres, and then kind of 1 to 2% from ED. So predominantly from kind of opted in general practice, but you're right, if you went in and Googled, you'd find us. But what we do is that practices come through their general practice first and then on to us. But again, if you stumbled across us or someone's told you how awesome Practice Plus is, then it is free to access. We like practices to sign up. We've got a whole onboarding package. We've got posters and marketing material, and it does work best, when you pop the Practice Plus logo on the practice website, because it's that kind of seamless. Patients trust it more if they've gone through their general practice. You are putting your credit card details online, and we know how nervous everyone is around that. So if it comes via your practice, there's just that higher trust level. So.
Speaking of the unenrolled side, have you guys thought of, because it is quite a big problem of, I guess, maybe doing information out to try and reach sort of more of that unenrolled population, like particularly in like the Wairarapa, for instance, where you were doing a case study? Were you advertising or putting up the number at sort of relevant places to capture more of that unenrolled population?
Yeah, so we were lucky enough that it aligned with some of their winter planning. So they did a big push in their community around, and I think many regions did this, about where in the system are you best placed for your care over the winter. So as part of that, they obviously got local rags and things like that. So we put Practice Plus as one aspect of the care system that they could access. So we did a bit of, obviously that's kind of not direct marketing, I don't like that term, but comms out to the community. As I said, pharmacies are a big one, and also letting practices know, because people obviously are ringing to try and enrol, and it's awful turning people away. So and I think we could do more in that space, and we've got some planning coming up. So it's a multi-pronged kind of approach, I think. So we're quite careful in that space, because we've always committed to our networks that we don't market direct to patients. So yeah, we're not going to go on Instagram and Facebook and say, come to us instead of your general practice. So yeah.
Excellent. Does anybody have any questions they wanted to bring up for our last kind of 5 minutes? Because it is quite an interesting space, because that's, as you're saying, it does, you don't want to be taking, it's supplementing. Yeah, and just how kind of everybody works together and addresses the demand in the different areas. Oh, there we go. Shira's got a question.
Just to clarify, this is really a pay-as-you-go space, isn't it? There's no other way around that at all. So if you can't afford to go to Practice Plus, there isn't. That's that. Is that correct?
So as I said, I mean, we were lucky in the Wairarapa initiative that Te Whatu Ora identified that and provided some subsidy in the voucher space. But unless, there is, I mean, and that can be funded by anyone, the PHO practices with SIA or flexible funding. There's a whole, as I said, and that's why we like to work in different regions, because there's other things that we can tap into, because there's financial barriers, isn't there? So how we go about that, we just have to get creative sometimes in that space.
Thanks.
Any other questions? Rebecca, did you have one?
Yeah, I did. Sorry, I didn't know whether I was on or not. Hi, I just wanted to ask about access for Practice Plus for the elderly who are not very computer savvy. Is there any assistance there for them?
Yeah, so I think that Telehealth Assist model is a really good approach. So whether it's done at practices, or we can get those kiosks into a number of areas. So there's talk again, and each region may come up with a different model, and we're happy to kind of work with them, likes of the kiosks, having a navigator or a health coach or a healthcare assistant to help people book is always something that kind of, the more we can do that, then the more comfortable elderly will be, because they are nervous about, we're all nervous about putting credit cards in, aren't we? So I think the more we can support, it's probably isn't a bit like the patient portal, helping people sign up and register, and then once they're in, that's half the battle won. So
thank you.
Just on that point, Jess, is there opportunity to kind of explore the telehealth assist model to be supported by, say, a marae, for example? Have you kind of explored that for some of the communities? I guess the general practice will have to be connected already with them. And if I think about Carol Coyne, who used to be with our team, for example, when they took the COVID vaccinations out, they did vaccination clinics within the marae. So, that community, for example, might be a really good example of we're actually doing telehealth assist at the marae, where people already see it and they're a partner already with the general practice. Will be great. Yeah,
and I think that's the future, isn't it? It's like that locality model where it's everyone working in partnership. So I think that's the best. A bit like the again, going back to the Wairarapa one, we had, you know, a whole range of partners, and we could probably bring in more where that actually works more successful. And especially for the likes of the PHOs, for example, have got the local relationship. So if we, you know, say Practice Plus went to the marae and said, hey, we'll do a telehealth, who are you, you know, so it's bringing that trust and rapport and things like that at the local level, and then using Practice Plus, a national service, to complement that. And that's where we can be flexible up to a part and work together to find the model that's going to fit. So we've done that actually. The Arahi in Northland is a hub for the community population who are struggling to get in up north. So we've been working with them. They've got a call centre with navigators, and then we just provide the clinical capacity. They wrap around the patient, and if the patient then needs a doctor's appointment, they've reserved a number of consults in the week, and their call centre just contacts us and we pop the patient in. So we're just complementing on the side with that. They've got their whole model of care, and we're just one small part of that. So that's where we see the benefit. We're happy to kind of be a big part of the model or a small, you know, jigsaw piece.
Yep.
Amazing. Sorry, I was just rearranging my windows. That's great. Really, I've thoroughly enjoyed everybody that's come to talk today. So I just wanted to say thank you, Jess, for taking time to talk to us about Practice Plus, and also to Lucy and Amelia for your presentation in the first half. So is it okay if somebody did have questions, can they reach out to you, Jess, or maybe just onto your website? Or
Absolutely. I'll pop my contact details in the chat, and then, yeah, feel free to reach out and start a discussion.
Amazing. And, you know, I just out to thank you for everybody else for taking the time to come today. You know, we are trying to sort of address the need that is in the community, and, you know, the areas that you guys are looking for information for. So if somebody does have something in particular, they're like, actually following on from this would be great to do that, like, just let me know, and I'll, you know, see what we can facilitate. And we'll be coming up with, you know, topics as well, but it's just good to get everybody involved in there. So just want to say thanks for everybody coming today. I will close off with a karakia. Got it on here. So I've got ko ranganui I tunei, ko pepatuanuku I toku tunei, kia tau te rangi marie, ki runga I tō tātou mahitahi, haumie, huie, taikia. Amazing. Enjoy the rest of your day, everybody, and we'll see you next time.